I request Dr. Neeraj Gupta to kindly start with the session.
Thank you very much, ma'am. And first of all, I would like to thank Dr. Akash and the Lucknow Neonatology Foundation for giving me this opportunity. I hope my voice is clear and the slides are clear. Ma'am, is it clear?
Yes, Neeraj, you are audible and your slides are clear.
Okay, thank you. Thank you. So, continuing in the series, today we'll be talking of another topic, that is management and prevention of neonatal infections. So sepsis is not a very new thing. If we see the literature, it dates back to as in the Hippocrates, in the BC. And from then till now, this has always been a hot topic, and to an extent that in 2017, the WHO declared sepsis as a global health priority. It is affecting the whole globe, and to such an extent that it is to become priority. So today, why we are focusing on the neonatal sepsis. So if we see the data, it's very surprising. We have a huge burden and of the neonatal sepsis. And this data which I have taken is from a systematic review done by Dr. Sumanchi Vasia, Dr. Jiva and group. And they have tried to collate the data from the Southeast Asia part. And this data is basically from our own country. And if you see this data is from the hospital-based studies. Our clinical sepsis, or so-called suspected sepsis incidence, is ranging from 50 to 170 per 1,000 live births. And the culture positive sepsis is 16 per 1,000 live births, which is almost 10 to 20 times higher than what we see in the developed countries. And see this, the case fatality rate, which is almost 34%, means 1/3 of the babies who are having sepsis, they are dying. And meningitis, again, almost from varying from 1 to 6 because of the different definitions. And this study, which is a Delhi neonatal infection study, a multicentric study from our own country. And if we see the data, this is even much surprising. The clinical sepsis is in the same range, 143, but the culture positive sepsis is almost 62 per 1,000 live births. This is very dismal, but then that's a fact and we need to accept it and work hard on this area. And if we see the case fatality rate in this sepsis, it is 25% for the total sepsis and 50% in culture positive. Imagine half of the babies who are developing sepsis, culture positive sepsis, they are dying. A very dismal situation. So apart from the huge burden, as I've already highlighted the case fatality rate, it is the second commonest cause of neonatal deaths, which all of us are aware. And it is not only the deaths which are the direct causes. If you see the babies who are premature, which is the topmost reason for neonatal death, maximum deaths among premature babies are because of this. Similarly, babies who have malformations, who have asphyxia, a lot of these babies are managed in the hospitals and they develop healthcare associated infections and they die. So directly or indirectly, it is one of the important cause of neonatal deaths. And those babies who survive, when they go to the community, they need a rigorous follow-up because the odds of developing poor neonatal outcome in these babies is to the tune of three times. And of course, it is adding a huge economic burden. So further, the problem gets dismal because of this issue of antimicrobial resistance. This is a newspaper cutting in last year, where they showed that the New Delhi superbug was found 12,000 kilometers away. The kind of resistance, antimicrobial resistance, which is spreading across the globe. And this data is again from the same systematic review published in BMJ in 2019. Here they have tried to show the data from the hospital settings as well as the community settings. And if we see here, the commonest bugs, the Klebsiella, the E. coli, the Acinetobacter, and the Staph, these are the 4 commonest bugs. And if we see the kind of resistance, the resistance in the community as well as in the hospital setting to the ampicillin of these bugs is varying from 70 to 90%. Imagine that if the resistance is 70 to 90%, what are you going to give? The ampicillin is not going to work at all. And if we see the resistance for gentamicin and cefotaxime, it is to the tune of 50 to 75%. And for ceftazidime, it is 50 to 70 to 75%. The biggest issue here is, which is more problematic, is the resistance to the meropenem. And if we see the resistance to the meropenem, it is to the tune of 10 to 65%, which is one of the high-end carbapenems. And the babies in the hospital settings who are developing sepsis, these bugs are resistant to that meropenem. And to more surprise, 50 to 85% of these bugs are multi-drug resistant. So you can imagine, multi-drug resistance means that the organism is resistant to at least 3 different classes antibiotics like aminoglycosides or carbapenems or fluoroquinolones. So at least 3 groups. So this is the kind of situation. So on one hand, we are dealing with a problem. On the other hand, that whatever the treatment is available, if the resistance is going to be so high, then what are we going to do? So I'll be briefly touching today upon the optimization of the management of these babies, primarily focusing on the role of supportive care, the need of rational antibiotic therapy, and any role of the currently available adjuvant therapies. And yes, of course, we know the problem, then how we can prevent this issue. Before I go to the management per se, let's look at some hard facts about neonatal sepsis. So most neonates have subtle and non-specific manifestations when they present with sepsis. Most frequent diagnosis is neonatal sepsis, but unfortunately, one of the most frequent dumping diagnoses is also neonatal sepsis. Most diagnostic markers which we do use day in, day out in our routine practice, they have low yield to predict sepsis. The positive predictive value is very less, though they have a reasonable negative predictive values. And most common type of sepsis which we encounter is culture negative sepsis, which is the major Pandora box which we do. Most bugs which we see in Southeast Asia, as I highlighted just now, they are resistant to the ampicillin, the drug which we have been using since decades, but the kind of pattern which is evolved. And most important part in the management is a good supportive care along with timely initiation of appropriate antibiotic therapy. And most of the adjunctive therapies, as of now, they have no role, but in future, yes, they will play an important role. Now, coming to the management per se, needless to highlight that the first and foremost part when we are dealing with any sick baby is the stabilization of the baby. When the babies are coming to our emergencies or they are in the labor room, the foremost thing is to, in the emergencies areas, is to triage, and of course in both the areas, you need to stabilize. And when we are stabilizing these babies, we should keep our mind open to consider other differentials. Unfortunately, we have been tuned that any sick baby, start IV fluids, start antibiotics. That have been the conventional treatment, but I think we need to move away from that and think beyond sepsis. And supportive care plays a very important role. And once we have done the initial stabilization and considered about the other differentials and started treatment, we need to give proper therapy, how to give, which antibiotic to choose, how to escalate or de-escalate, and for how long to give. So the first and the foremost part is the triaging. So based on some symptoms, you need to prioritize your baby, whether the newborn qualifies for emergency signs or priority signs or non-urgent signs. Because at this time, if you have not given due consideration, it may happen that by the time you are going to take history and doing examination, you have already lost a child. So triaging is very important. And it is always a good idea in these areas to have a checklist so that one can look at that whether the supplies which are required for the initial stabilization they are proper or not, whether you have you missed anything in the assessment. So if you have a checklist, anyone can go through that checklist and immediately say, yes, my baby qualifies for emergency signs, I need to immediately go for the emergency treatment. Once we have triaged the baby, then the foremost thing is to initially stabilize. As I said, this is very crucial. And again, the basics remain same, that we have to first look at the temperature, try to maintain, put the baby on the radiant warmer, try to maintain the temperature between 36.5 to 37.5. Need to take care of the airway and breathing, reposition the neck, do airway suction if required, and look at things. If the baby is not breathing or apneic, you need to start positive pressure ventilation and manage accordingly. If the newborn is in shock, of course, you need to assess and start with bolus or inotropic support as the need arises. If the baby is seizing at that time, you need to give to check sugar, simultaneously calcium, and give bolus. If it doesn't improve, then of course you need to give anti-epileptics. But never forget to check sugar. In fact, sugar should be considered as an extended vital in these babies, and it should be always part and parcel of the initial stabilization. This area of triaging and emergency areas or labor room areas, the babies are sick, so never hesitate in calling for the help, because it may happen that you may not be yourself alone to be able to manage the things. And when we are busy in managing these babies, there are high chances in these areas that we may breach aseptic protocol. The baby has come for some other reason. It may not be sepsis, but unfortunately during that intervention, you have given infection to the baby, and which is going to have its own repercussions. So try to keep aseptic protocols in mind. Then the question is that a sick baby in your labor room or in emergency, or when you are taking rounds in the ward, suddenly the mother says the baby was fine and now the baby is not, is lethargic, is not moving, is not responding. So question is it sepsis or are we dealing with something else? So in all the areas, whether we are talking of labor room or emergencies or wards, always keep, whenever you are encountering any sick baby, keep this mnemonic in your mind: the misfits. This mnemonic quickly tells you the commonest differentials which should be considered in such a newborn, especially the drug-dependent cardiac lesions, whether it is drug-dependent systemic flow lesions or drug-dependent pulmonary blood flow lesions, or you are dealing with some inborn error of metabolisms, or babies presenting at day 7 to day 10 or the end of the first week of life with shock, considering congenital heterogeneous hyperplasia. So these are the commonest differentials which we see in these babies, but always keep your mind open for the other differentials rather than just jumping into the category of neonatal sepsis. But having said that, keep sepsis as always in the back of mind. The reason is because of its common occurrence. It's a preventable cause of death, and if you have ignored it, it is going to cause high mortality. So the first shot of antibiotic has to be given as early as possible. Even because in the first go when the babies are sick, it is not practically possible to be 100% sure that this patient has drug-dependent lesion or this patient has congenital heterogeneous hyperplasia or IM. So it is always better to take culture and start, give a shot of antibiotic, do your investigations, and try to see whether it fits into some other pathology and plan accordingly. Coming to the supportive care, all of us are aware what needs to focus. So I just like to highlight that when you maintain the airway and breathing, keep that in mind that apart from your care, the patient should not get any kind of adverse events later on. So try to maintain targets, saturation targets between 90 to 95%. Use some sort of scoring system for monitoring the respiratory distress. If there is any respiratory distress, give support based on the respiratory distress, whether the baby needs plain oxygen or you need non-invasive ventilation like CPAP, NIV, or baby needs upfront intubation. Of course, the circulation needs to be taken care. So depending on the situation, your thought process and the condition, one need to go for boluses or inotropic support. If the baby is reasonably stable, so you can start with IV fluids or maybe upfront feeds also, depending on the assessment. Never forget to look at sugars and monitor electrolytes. Remember that whenever we manage any sick newborn or any newborn per se, the ongoing monitoring is must, because it is monitoring which is going to tell you whether a newborn or the baby is improving or deteriorating. The actions which you have taken on the baby, they are making some sense or they need to be improved or the management has to be changed altogether. So this will come through holistic monitoring, which means you need to monitor all the systems, not only focusing on the one system. And more so in sepsis, because even sepsis, when you give some antibiotic therapy, remember that antibiotic agents, they are going to take some time to act. It may take 12 to 24 hours. So in the first 12 to 24 hours, it is your supportive care which is going to change the management. If your supportive care is good, the outcome will be good. If your supportive care is not good, especially in the first 24 hours, you may not be able to salvage the baby, despite of giving best appropriate antibiotic. Coming to the antibiotic per se, all of us are aware that why appropriate antibiotic therapy is required. These are various general adverse events of inappropriate therapy, and especially the antimicrobial resistance which we are dealing. And of course, it increases the hospital stays and cost. But for newborns, there are few particular side effects. If you give unnecessary antibiotics, it may increase the odds of necrotizing enterocolitis or the incidence of late onset sepsis, and to an extent that it has been shown that it increases the odds of mortality. And it also alters the gut microbiota, the microbiota which is present in the gut gets altered, and which is implicated in the pathogenesis of so many diseases in later life. Moreover, it also increases the risk of childhood wheezing as well as obesity. So one need to be very cautious whether antibiotic has to be given or not, and if given, then which antibiotic. Equally important in this setting is that one need to use the right dose as well as the right duration of infusion. Of course, sometimes we forget these issues, whether the dose is proper or the duration has been proper or not. And in that, it decreases the efficacy of that antimicrobial agent, resulting in prolonged therapy and its, of course, consequences. So how to choose the initial antibiotic? Remember that the first antibiotic which we choose after taking blood culture is purely empirical, and it has to be broad spectrum, so that you want to cover both gram positive or gram negative. And this empirical antibiotic, the choice of this empirical antibiotic is based on the suspected bugs and the sensitivity pattern of your unit. So it is important that all those who are managing these babies, they need to have their own antibiogram based on the culture reports. If you don't have your antibiotic policy based on your antibiogram, then it is very difficult to make out which antibiotic has to be given. So it is a good idea to take 6 to 12 months data of your cultures of which are being coming positive, and try to make an antibiotic policy. The first line for antibiotic agents which you are going to use should be able to cover 70 to 80% of the bugs which are going in your unit. Second line, of course, 80 to 90%, and third line around 90% plus. Try to cover gram negatives because those are more common. But if you suspect gram positive like staph, because there is an evidence of pustules or some abscess on examination, then do try to give gram positive cover. But try to avoid cephalosporins as the first line, because if you use cephalosporins, it has been shown that they increase the risk of extended spectrum beta lactamases as well as fungal infections. So use cephalosporins once you have a confirmed meningitis or you have a strong suspicion based on the clinical symptoms like bulging AF or seizures at presentation, where you have a strong suspicion of meningitis. Only then use cephalosporins as the first line. Otherwise, have restricted use. So this is just I'm showing the antibiotics which we are using in our own neonatal unit based on our own antibiogram. So all units have their different protocols, and we primarily use augmentin amikacin for early onset sepsis and as the first line, and in suspected late onset sepsis we are using piperacillin tazobactam plus minus vancomycin if the patient has catheters, and we switch over to meropenem and vancomycin as the second line if the patient doesn't improve. And those newborns who are coming to our emergencies, if they most of the time they have received antibiotics outside, but if someone is directly coming from home, then we use the same antibiotics of augmentin, or sometimes we, and if there is suspected meningitis, we give cefotaxime on that. And if they don't improve, we go to the second line antibiotics. Colistin and amphotericin B are the reserve. So no means you need to make your own antibiotic policy. So depending on what kind of cultures, the sensitivities of these cultures are coming. If the local antibiograms you don't have, then what is the answer? I think there is no straightforward answer. It's a good idea that if you don't have, then try to take someone's help. If the culture facilities are not in your unit, if there is a possibility by doing some public-private partnership, or then try to send those cultures. If nothing is available, then try to see some unit in your area which is catering to the same kind of profile of newborns which you are dealing, and try to see their data and try to extrapolate that data and try to use the same data in your unit also. In case if nothing is available, so this slide I have taken from this information from Dr. Jiva. So his courtesy, he shared this data with me. So based on their systematic review, which was published in BMJ, the initial slide which I showed you, they have come to the conclusion based on that in these situations, if the strains are sensitive, if the situations where the few strains are likely to be resistant, those units can use MP or fluoxetine with aminoglycosides as the first line in cases of sepsis or pneumonia, and for meningitis they can use MP and CFO. But where, as I showed, that if the strains are resistant, as like we showed that almost 80 to 90% are ampicillin resistant, so these units may use cipromica as the first line and piperacillin tazobactam amikacin as the second line. And if they're suspecting MRSA, they can add vanco. So these are all purely empirical. So the best is to have your own unit data. Now, once you have started antibiotics, empirically antibiotics based on your antibiogram, there are two possibilities. Your baby is going to clinically improve or your baby is going to clinically worsen. Now, if the baby is clinically improving, which most of the time which happens in our setups, and we collect the blood culture report, If the blood culture report is negative, then continue the empirical antibiotic for 5 to 7 days. If the course is consistent with sepsis, this is very important. If the course is consistent with sepsis, only then, and the culture is negative, only then continue empirical antibiotics for 5 to 7 days. Otherwise, if you have started empirical antibiotics, but the baby improved immediately, the course is not consistent with sepsis, the culture is negative, then there is no point in continuing antibiotics. In fact, that was not sepsis at all. So you have a second situation where the baby was improving, and this time the blood culture was positive. If the culture is showing a bug which is sensitive to the antibiotic which you are giving, then remember to de-escalate to the narrowest spectrum sensitive antibiotic. Unfortunately, so many times it happens that we are giving some antibiotic and we have, even if there is an opportunity to de-escalate, then we don't de-escalate. This leads to more of antibiotic resistance and of course misuse of antibiotics, its own disadvantage in terms of cost and duration of therapies. So always try to de-escalate. The basic principle in de-escalation is that one need to shift to monotherapy if possible. Suppose you have started with vancomycin and piperacillin tazobactam and your culture is showing gram negative bug, then of course you can straightforward you can stop vancomycin. That is first principle, that try to shift to monotherapy as far as possible. Second principle of de-escalation is that try to choose the narrowest spectrum antibiotic. So if that bug is sensitive to, let's say, amoxicillin, then try to use amoxicillin rather than piperacillin tazobactam. If you were using meropenem and the bug is sensitive to piperacillin tazobactam, try to switch over to piperacillin tazobactam. So the idea is that you try to choose the narrowest spectrum sensitive antibiotic. Now suppose if the baby was improving and your culture is positive, but the bug turns out to be resistant. This is not a very common situation, but yes, it happens sometimes that the baby is improving with the antibiotics we have given, but the bug is sensitivity report shows that the bug is resistant. It's a tricky situation. It means that probably there is a difference in the in vivo and in vitro sensitivity. So in these situations, the baby needs very close monitoring. One may take help of septic markers. There is no clear-cut evidence, but one may take help of septic markers to look at the trend that the antibiotics which you have given, whether the baby is clinically improving, whether the CRP or the PCT, the CRP is decreasing. If that is the case, then you closely monitor and continue that empirical antibiotic. But in case if your baby has meningitis or other CNS infections or other deep-seated infections, then in this situation, try to switch over to the sensitive antibiotic rather than continue your empirical antibiotic. Second situation is that you have started empirical antibiotic, but the baby is clinically worsening and the blood culture report turns out to be negative. Then of course, as we know that in these babies, we need to change to our second line antibiotics. And if the blood culture is positive, then I think it's a win-win situation. The baby is deteriorating, the blood culture is positive. So you take a call based on your culture report and upgrade that antibiotics as per your culture sensitivity. So when to choose a second line antibiotic? As I've already conveyed that if there is no response or worsening after 48 hours of starting first line with blood culture being studied, if the culture is positive, then you change according to that. Otherwise, you go with that. Apart from that, there will be some situations that you have started first line, but there is a very rapid worsening and you feel that the baby will not give you time. So in these situations, when it's justified in directly shifting to second line, the one may argue that it is a misuse, but then you need to consider that the baby is in such a situation where he or she is not going to give you time. And always consider vancomycin if not added earlier here, considering the possibility of methicillin resistant staphylococcus. Occasionally, it may also happen that because of the overcrowding or high load, less staff, the neonate has been picked up in for the first time in the life-threatening state, like shock. There also one may be justified in directly switching over to the second line antibiotic rather than choosing first line. But this decision should be always discussed with the seniors if available in your unit. So I've already conveyed that what needs to be considered by de-escalation, that try to switch to monotherapy. So out of 2 gram positive, gram negative, try to stop one antibiotic. And second is try to choose the narrowest spectrum sensitive antibiotic. The examples I have shown you that if your bug is sensitive to fluoxetine, let's say you started vancomycin, but the bug turned out to be MSSA instead of MRSA. So though the baby is showing response to vancomycin, but please switch over to fluoxetine. In fact, it has been shown that if you continue with vancomycin in this situation, rather the bug takes more time to get eradicated from the, it takes more time to get eradicated from the body. So, and then we'll be further adding resistance to vancomycin. So please switch over, please de-escalate to cloxacillin. So as I've already highlighted that these are other issues, the proper dose. So you need to consider that whether it's a routine infection. Routine means that non-CNS infection versus CNS infection, because we know that the doses are different. In the CNS infection, you need to give higher doses so that they can penetrate the inflamed meninges. Another important concept is the duration of infusion. We have two broad group of antibiotics. One is time-dependent killing and one is concentration-dependent. Time-dependent killing means that the level of the antibiotic in the blood has to be above that minimum inhibitory concentration. So for longer the duration the levels are there, better is the killing power of that antibiotic or the efficacy of that antibiotic. Concentration dependent is that the killing power depends on the peak level. So the typical example of concentration dependent is your aminoglycosides. That's why you'll find that we give aminoglycosides over 15 to 20 minutes. In the OD dose, we never give aminoglycosides BD or TDs because we want a rapid increase in the concentration of the aminoglycosides in the blood, because the bugs, the aminoglycoside act through the concentration dependent mechanism. Whereas these carbapenems, the piperacillin, tazobactam, the meropenems, they basically act through the time dependent killing. So longer is the concentration in the blood, better is the efficacy. So they are given as an infusion to over 2 to 4 hours. So please do not give these antibiotics over 15 to 20 minutes. Otherwise, the efficacy will decrease and you need to unnecessarily combine with more prolonged antibiotics. What else I need to keep in mind while giving antibiotics? Of course, there are a lot of host factors and drug factors. We all know we need to look at some formulae like Neofex to look at the doses based on the gestational age and postnatal age. If the newborn has acute kidney injuries or deranged LFTs, then you need to do proper renal or hepatic modification of these doses. If you're suspecting meningitis, you need to start give doses in antimeningitis, especially the cefotaxime. Try to avoid ceftriaxone, especially when the baby has jaundice, because it displaces bilirubin and can predispose for acute bilirubin encephalopathy. If you're suspecting bone and joint infections, of course, gram positives are the major culprits here. So one need to directly cover this staph aureus. So either use aminoglycosides, and if there is a possibility of MRSA, then directly switch over to vancomycin. Of course, we do consider drugs side effects while giving therapies. And if there is a high toxicity, then we need to change to some other drug based on the culture sensitivity report. And nowadays we have Vitex systems, the various automated systems, which gives you the, apart from the sensitivities, they also give you minimum inhibitory concentration. So one can look at the therapeutic index. So there is a, so these systems, what they give is, they give you a MIC, minimum inhibitory concentration, that if the concentration is above this, the organism will be killed or suppressed. And there is a breakage point. So breakthrough point and MIC gives helps you in calculating the therapeutic index by just dividing one over the other, and it helps. So one need to look at the therapeutic index of the various sensitive antibiotics and then take a call. So MIC values can play an important role in antibiotic stewardship program too. So what should be the duration of antibiotics? Till now, what we have been using are purely magical figures. We don't have much evidence in this direction. So some evidence is there where people have tried to use short courses versus the standard durations. Studies from Rohtak by Dr. Geeta Kitwala and from Saurabh Dutta sir and the group. So they have compared short courses like 7 days or 10 days versus 14 days for culture positive sepsis. And these trials have been done in basically babies less above 1500 grams. And they have shown that apart from staph aureus, these can be used. There was not much of relapse, but then overall the quality of evidence is not very good. The kind of outcomes in terms of these are only, they have looked at death, a very short relapses in 7 to 14 days. So we need more data in this direction. So though there is some evidence, but then this is not sufficient to change the current conventional numbers which we have been choosing. Similarly, people have argued that can we use serial trend of C-reactive proteins or co-calcitonin guided therapies to decide stoppage or to decrease the duration of antimicrobials. So this is a famous trial published in Lancet, that is NeoPinch trial, neonatal pro-calcitonin intervention study. So this NeoPinch trial has shown that in early onset sepsis only, it is for early onset sepsis that if you have 2 consecutive PCTs done 12 hours apart, and if they are below that age-specific cutoff, we know that PCTs cutoffs are very variable in first 72 hours. So if they are both the values are below that, you can safely stop antibiotics. Similarly, but we don't have data for the PCT role of PCT in the late onset sepsis. This is only for the early onset. For CRP, we have some data for both early onset and late onset, where people have shown that if the 2 consecutive values or a single value is less than 10 milligram percent, then one can safely stop antibiotics. But as I said, that overall this quality of data is not good. So there is some pointing. We need more evidence in this direction to change the current practices, whether CRPs or PCTs can be used straightforward to decide the duration. So conventionally, we have been using these figures. So if the course is not suggesting sepsis, or the antibiotics were started only due to the risk factors like clear-cut choreo in a preterm baby less than 32 weeks, and though the baby was asymptomatic. So in these cases, these stop the antibiotic as early as possible once the blood culture is trained. Remember that 90% of the blood cultures become positive by 48 hours, and even earlier for the gram negative. So if we see the difference in the gram negative bugs, they become sterile very quickly. So almost touching 90-91% by 24 hours instead of, whereas the gram positives take slightly more time to come up on the blood cultures. And by 72 hours, by and large, all the culture positivity comes up. So if the baby has culture negative sepsis, but the course is consistent with sepsis, then the duration of therapy which we have been using is conventionally is 5 to 7 days. For culture positive sepsis, 14 days, for meningitis, 3 weeks, for ventriculitis, 4 to 6 weeks, and for bone and joint infections, again, 4 to 6 weeks. Sometimes we face this situation, in fact, when the baby has culture negative sepsis, which means the course is consistent with sepsis, and the course was terrific. Let's say the baby had shock, scleroderma. So no one actually knows that what should be the ideal duration, but yes, people have been using little prolonged duration of antibiotics varying from 7 to 14 days. So some people will give 10 days, some people give 14 days in these cases also. So no one knows what is right, what is wrong. But yes, when they do tend to prolong antibiotics duration in these cases when there were these kind of complications in culture negative sepsis. So we have a scenario like a 30-weeker, 11 50 grammer AFD male born by section due to the maternal sphere preeclampsia, not a very uncommon situation. Infant cried, got shifted to NICU being 30-weeker, 11 50 grammer, was asymptomatic and was started on IV fluids and feeds. But simultaneously, the antibiotics were also started. Question is that whether the antibiotics were really required in this situation or not. So remember that there is no role of prophylactic antibiotics. Any asymptomatic preterm admitted to ICUs, asphyxiated babies, meconium aspiration syndrome, jaundice, exchange transfusions, insertion of central lines. No, none of these conditions warrant antibiotics. We used to think that antibiotics are Gangajal, but come out of this notion. They create more issues rather than giving, helping us out. They help us out only in specific situations, but not enough. So please don't use any kind of prophylactic antibiotics. Strictly no. Also try to establish the culture of sending blood cultures in your unit. And before you start antibiotics, always take blood culture. Remember that you need to take proper amount. There is ample data which shows that if your amount is less than 1 ml, then the detection rate decreases to the tune of almost 40%. While collecting blood culture, always take due aseptic precautions. And once you have taken the culture, try to send to the laboratory as early as possible. And if it is not possible, then please keep it at the room temperature or an incubator if it is there. If you don't have, then please, if incubator is not there, then please keep it at room temperature, but please do not refrigerate these bottles, because temperatures of 4 degrees Celsius, which are in the refrigerator, it is going to suppress the growth of the organism. And we, after the reports, we, after the microbiologists, try to develop a system that through WhatsApp or telephonic conversation that you get the reports as soon as it is available. It is very important that you believe in your culture reports and always try to review at 36 to 48 hours of starting antibiotics whether my baby really need to continue antibiotics in my baby. It may happen that the initial thought process was right, but the baby improved very quickly. The culture is sterile. There is no need to give antibiotics and you can immediately stop. Or if the baby's course is consistent, look at the report. Culture is positive. Try to see whether there is any de-escalation which is possible or not. So always review your reports, review the baby holistically at 36 to 48 hours of the reports. So develop a unit protocol for antibiotic prescription, use maximum 4 or 5 antibiotics, document any change of antibiotic, that why you have started, why you are changing, for how long you are going to give, and it should be under the control of consultant whenever you are going to change, and never forget to send the blood culture before any change. So by following these simple measures, one can go more towards antibiotic stewardship. Coming to the invasive fungal infections, so we know that most of these infections are primarily caused by Candida species, and whenever you are getting any kind of invasive fungal infections, always try to screen the end organs like eyes, CNS, kidneys, and heart to look for these organs. And if you are encountering fungal infections, please immediately remove your central venous catheters, because it has been shown that if the CVC is not changed, it actually increases the duration of therapy as well as increase the mortality risk in these babies. So please remove catheter, CVCs unless it is not required. If the baby is very sick, then that may be an exceptional situation. Usually fungal babies with fungal infections are not that sick. So try to remove that catheter as early as possible. One can put after 3 to 4 days or once the culture becomes dry. And the duration of therapy in fungal infections is at least, so one has to give 2 weeks after documenting the clearance of Candida species from the bloodstream. The drug of choice for antifungals is amphotericin B in dose of 1 mg per kg per day. Remember to monitor RFTs in potassium. Fluconazole is used as an alternative, but primarily amphotericin B is the drug of choice. Usually newborns tolerate it well, so there is no need for liposomal. Liposomal has to be used only in selected cases where there is a toxicity because of amphotericin B, or there is a fluconazole resistance, so you are not able to use amphotericin B or fluconazole. Only in those situations use liposomal, and of course amphotericin B is very cheap as compared to your liposomal amphotericin. Remember that in renal candidiasis, please do not use liposomal because of the poor penetration in the tubules, and it is not able to clear that infection. If you have CNS infection, fungal infection, again the drug of choice is amphotericin, and flucytosine is used only as a salvage therapy along with amphotericin B, where there is no clinical response, and the duration of therapy is more prolonged. Once they are, apart from not only the clearance, 2 weeks beyond clearance, but you need to see whether there is a clearance of CSF as well as the radiological abnormalities have resolved. Coming to the adjuvant therapies, people have tried to use a lot of immunotherapies. The reason is because we know that the immune system of the newborns is immature. So people have, whether you talk of innate immune mechanisms or you talk of adaptive, so people have tried to use different strategies by a lot of products which are normally available in the breast milk, or these therapies like IVIGs, colony stimulating factors, or granulocyte transfusions. Now I'll just quickly touch upon IVIG. For all practical purpose, both IVIG as a treatment as well as a prophylaxis, there is no role. For granulocyte colony stimulating factors or granulocyte monocyte colony stimulating factor, again, whether as a treatment or as a prophylaxis, there is currently no role. Similarly, for granulocyte transfusions, there is no role because all these therapies have not been able to show a decrease in the mortality. If we come to the lactoferrin, a lot of work has been done on the lactoferrin, which is bovine based. It is actually also a glycoprotein which is found in the breast milk also. It has multiple properties. If you see these previous strategies, they were focusing only on the one part, whereas this therapy is acting on multiple. It is a bacteriostatic as well as cidal. It also promotes the innate and adaptive immune system, and it also promotes the intestinal microbiome. We don't have any, as of now, the RCTs are going on, but we need more evidence whether it can be used for the treatment of immunodental sepsis. We don't have evidence at this point. But for prophylaxis, like if you give lactoferrin in the babies, like probiotics, for prevention of sepsis, so it has shown that it decreases suspected or confirmed late onset sepsis, and when you use along with the probiotics, it again has shown better effect size by this. So though the overall evidence as of now is low quality, but it seems to be a promising molecule in near future. If we see zinc, again it acts at multiple pathways. It has shown to decrease the all-cause mortality, but there is no effect on sepsis or NAC. If we look at probiotics, all of us are aware that it decreases NECs and all-cause mortality. But if we look at sepsis, the overall evidence if we see that there seems to be some reduction to this confidence interval of 0.97 is very close to 1. But when the sensitivity analysis was done by looking at the high quality trials, they found that there is no reduction. But anyways, in all very low birth weight infants, most of the units are using probiotics, which is standard of care because of its role in decreasing NEC and LOC, NEC and all-cause mortality. Pentoxifylline as well as melatonin and exchange transfusions. These are the modalities where we need more evidence. They have some promising role to play. Exchange transfusion, one can take a call on case-to-case basis, though it has shown to decrease mortality. But most of the studies have very high risk of births. So for all practical purpose, there is not much in the adjuvant therapy as of now, but we still have some molecules like pentoxifylline and this lactoferrin, which is an upcoming. Now, coming to the prevention part, we know that healthcare associated infections, they are a major public health problem, and they have significant impact on the morbidity, mortality, as well as the quality of life. And because of this issue, it has become the priority. Even nowadays, insurance companies are seeing that which hospital has more healthcare associated infections, and they don't try to support that because it's a major burden onto that cost part. So always, as we say, prevention is better than cure. So let's see what we can do. But one thing I would like to highlight that for preventing infections, one need to be obsessed. Without obsession, and we need to improve quality of care. So we need to improve the quality of care, and that is the only way. And in fact, the whole neonatology revolves around the quality of care. So if you improve the quality of care in each aspect, the overall intact survival will improve. So we can prevent infections by changing our practices, some issues related to infrastructure and manpower, and by the surveillance. The surveillance is very important. Once we know that, okay, this is my baseline rate of infection, then I introspect and see what are the reasons and try to fix those problems. If that is the only way forward. We often forget labor room. The babies come from labor room and emergency areas, and so we tend to focus more on the NICU as well as the step down area. But remember that the babies who are being born are being managed in these areas. If there is sepsis protocol, there are high chances they get breached. So this is a study from the Pakistan where they have shown that by just looking at taking care of the basic things like the baby towels they changed, use of sterile gloves, use of hand rub, availability of clean delivery sets, they were able to decrease the infections from 63 per thousand live births to 14 per thousand live births. So never forget labor. In fact, start looking from the labor. Hand hygiene, Dr. Semmelweis, who described puerperal fever and told that hand washing is so important, but still in 21st century we are struggling. All of us are aware how to wash our hands, how to apply alcohol-based rub. But remember that most of the units are, there is always exchange of or rotation of the staff. So which should be avoided. Some staff is coming, some staff is going. So it is always a good idea to reinforce them. Also, it is important to see that though we know all of them, but in these 5 places, these 5 movements, so when we have to follow these hand hygiene measures, so it is important that it is not only before touching a patient, but also after body fluid exposure, after touching patient, and any paraphernalia we are touching the baby. Before and after that, we need to use hand hygiene measures. And simple measures like availability, provision of the continuous water supply. Most of the time we don't have elbow operated taps. Simple things we need to see and try to fix in our system. And of course, there is a lot of role to play by training, education, and taking feedback and motivating people who are doing good. So one need to find contextual factors that why we are not able to fix the problem, try to see, fix it, and improve your hand hygiene rates. Second broad strategy is that you follow what you say bundle approach. So the most common intervention which we do is putting a peripheral cannula. So there has to be clear cut insertion bundle and maintenance bundle, and always use checklist. Remember, never forget to clean the hub with alcohol before and after using or giving medications through the cannula. Never use stock solutions. If you have facility for laminar flow, try to prepare a fluids drugs into laminar flow, and do not reuse the single dose medication ones. For preventing central line associated bloodstream infections, we know that there are two kinds of contaminations. One is intraluminal contamination, one is extraluminal contamination. So, so the hub contamination which occurs, and then you have so the infusate means the fluid which you are giving, the drug which you are giving, the hub, all these leads to endogenous contamination and infections. And whereas the site from where it is inserting, if you're not cleaning this site, it is a source of exogenous infection. So again, so you need to have clear-cut bundles. So insertion bundles, so always use checklist and see whether you are abiding to that. And another important aspect while putting central line is see that whether it is really required or not. And if it is required, then daily see whether you can immediately quickly remove it or not. So that holds true not only for central lines, but for catheters, for tubes, for ventilation. So anything, any foreign body which is into the body, try to take it away as early as possible. Longer it stays, more is the problem. And remember that when you are putting central lines, a dressing which you are using to fix it, it has to be sterile dressing, and it has to be semi-permeable so that you can immediately see if there is any kind of extravasation, and it has to be well applied. It should not be loose. Similarly, the maintenance bundles to prevent interluminal contaminations follow ANTTs, aseptic non-test technique. Try to minimize the breakage. Try to minimize the breakage, because more you break the center lines, you have more chances of infection. Again, never forget to take care of the hub by using alcohol swabs. Similarly, for ventilator-associated pneumonias, we know that what are the endogenous sources and what are the exogenous sources. The most of the exogenous sources come from our hand, the way we take care of hand hygiene measures, the kind of catheters, the kind of suction apparatus, the catheter, how much long it is going in. So these are simple things. How dirty is your what do you say, ventilator circuit. So again, try to see if you can avoid intubations. You can just go with a non-invasive ventilation. And if intubation is required, then try to decrease the duration of mechanical ventilations. We don't have clear-cut evidence for elevating the head of the bed in the newborns, but it has been shown to decrease IVH. And in general, most of the units are practicing, considering a lot of evidence from the pediatric and adult side. And regarding mouth care, we don't have any evidence for chlorhexidine in newborns. There is a published study pilot study which has not been able to show clear control of chlorhexidine application in the oral cavity. And again, there is not clear control for how frequently these circuits to be changed, but better to change after 1 week, and try to drain ventilatory these condensate, the water which condenses, if it is there in the circuit, then it again leads to a lot of infections. So try to move that. So whether it is gap prevention, whether it is central line preventions, the basic tool is that you need to follow a bundle approach, and you have to have effective surveillance mechanisms and continuous staff education to prevent infections. Skin, the largest organ of the body. So, and this is the skin is fragile. This is a big portal of entry. So remember, use skin-friendly adhesives, and while you remove it, be gentle. Similarly, with the babies on non-invasive ventilation, CPAP, a lot of skin injury takes place in the nose, nostril, which is a portal for entry, and leads to infection. So take care of that. So there has to be clear-cut SOPs for the housekeeping part, whether it is cleaning of equipment, whether it is cleaning of the surface, equipment cleaning, and similar things, which is very crucial, because all this decreases the surface contamination. So aseptic non-touch technique. This technique basically should be followed in each and every procedure. The crux here is that there are some key parts and key sites which should never be touched directly or indirectly. So you need 2 people and try to avoid touching that key part and key site. So like in a syringe, the tip of the syringe is a key part of that syringe. So try to avoid touching those areas. So ANTT is a principle which has clearly shown to decrease infections. All of us know the various advantages of breastfeeding and the various molecules which are present in the breastfeeding which prevents infection, which helps in preventing infection. So try to start early, have a clear-cut feeding protocol, promote early milk expression. So another strategy which people have tried is application of this colostrum on the oropharyngeal cavity. So this intervention has just shown to decrease the day to reach full enteral flow, but no effect on sepsis, NEC, or death. So we need more evidence in this direction. So though all the trials have shown the feasibility of this strategy, but we need more evidence to see that whether this can be followed routinely or not. AMC, all of us are aware that it prevents infections and it decreases infection to the tune of almost 50%, and same happens not only in the hospital but also in the follow-up people have shown. So try to start KMC early, prolong its duration, and it is important to see that what are the contextual barriers and try to overcome those barriers. Infrastructure and manpower, difficult to handle, difficult to solve these issues. So how the NICU has been designed, what kind of floor, whether there are any crevices, paints like epoxy coated paints are available, which decreases the infections. Similarly, you have aluminum composite materials which are placed on the walls, which again have been shown to decrease the infections. Then there has to be a facility for adequate air exchange, minimum 6 exchange per hour has to be there. The water supply has to be clean. Often we forget to look at from where the water supply is coming to the NICU taps. So it is very important for the periodic check as well as cleaning of those water tanks. There has to be facility for isolating the septic babies. Otherwise, the single septic baby or the babies who have like chicken pox, so who needs to be isolated, rubella infection. So these kind of babies who have weeping lesions on the skin, so they can be the source of epidemics, or if a baby develops diarrhea. So you need to have a place where you can isolate these babies and prevent sudden epidemic or surge of infections in all your babies. Of course, avoid overcrowding. So look at your admission policies. Are you admitting unnecessarily? And of course, adequate staffing so that people can follow the SOPs. There is some role of prophylactic antifungals in extremely overfed infants. It has been shown to decrease the risk of invasive infections to almost like 70%. But remember that all these trials, if you see, the baseline incidence of the invasive fungal infection in these units where these RCTs have come is very high, to the tune of 10 to 15%. So what ITSA recommends is that prophylaxis should be used only in the settings where the neonatal units have a high rate of invasive candidiasis, that is more than 10%, and it has to be used only in extremely overfed infants. And you have to use fluconazole. The dose is 3 to 6 mg per kg per dose. It has to be used twice weekly till 6 weeks, and you can choose any route. So if you have to decide your whether you want to use it or not, please look at your own unit data and strengthen measures to prevent it. Surveillance is very important. It's the key. You cannot prevent what you have not measured. So please follow the standard definitions and try to look at the units in your region, in your country, who are performing better, who have low infection rate. Try to see their practices and try to inculcate those things in your unit. So this is just one way to show that how you can plot on the and make run charts or control charts to see that how the interventions work. So this quality improvement, as I said, that this is a way forward because it is important that what you are doing, then you see what you make changes you can bring into your system. So you make a strategy, try those changes and see which is working, which is not working. And people have shown that by doing quality improvement measures and by doing regular surveillance, auditing, and feedback, you can decrease a lot of infections. Try to bring change in the system. This is a very old study, but a very good study which shows from AIMS Delhi. This was done in 1988 by Dr. Neeraj Gupta and group, where they showed that by these simple measures like reducing the unnecessary admissions, stopping the use of stock solutions, start preparing IV sites, they have been able to decrease the neonatal mortality rate by 1/3 and sepsis by 50%. So try to look into your system and bring changes, simple measures which can bring. Another example, this is study from SMS Jaipur by Dr. Ramesh Agarwal. So again, if you see that they have taken 2 periods, 2004 and 2005, And if you see that these simple changes which they did in their unit by restricting the admissions, clear-cut policies, by creating step-down areas, and following asepsis routines, promoting the feeds, rational antibiotic therapy, training of nurses, they were able to decrease the mortality from 29.3 to 20.3 and LAMA rate from 11 point. So you can see this in the neonatal mortality rate that how it decreased overall. And you can see the survival between 1000 to 1500 grams. So almost 50% reduction and then reduction in antibiotic usage. So I'll conclude by saying that supportive care is very crucial in the management of sepsis. Try to use your local antibiogram. If it is not available, please make it. Don't forget to de-escalate antibiotics. There is no role of prophylactic antibiotics, and one need obsession to prevent infections. Try to divert your resources to the basic evidence-based practices rather than focusing more on buying costly equipments. Periodic surveillance is the key, and try to follow antibiotic stewardship. Thank you very much, and a very happy Holi to all of you. I would be very happy to take questions.
Neeraj, as usual, you were too much engrossed, and so I tried to answer a lot of these simultaneously only because as a human mind, when there are questions in your mind, you want a rapid answer to it. So few of these, especially the question one itself, I did not answer because I do not agree with the use of sepsis score or sepsis calculator. And maybe if you would like to supplement on it, and then we can justify why we are not satisfied with this sepsis scoring system or use of the KP, your calculator, which is not designed and validated in our system.
So, Imam, I completely agree with you because all these calculators have been basically they have come from the developed countries, where in the early onset sepsis, the GBS is the predominant organism. So our profile is different. They are using intrapartum antibiotic prophylaxis. So I think we directly cannot extrapolate that to our setup. In fact, yes, I completely agree in the sense that there is a need to develop similar kind of calculators in our setup, but we cannot use those calculators in our system, in our setups.
And rightly said, if you look at their EOS and our EOS, they fill 0.5 per 1000. If I have to enter this, it will vary from 1.6 to more than that also per 1000. So we will land up practically giving to all. So we will later, once we are done with all the questions and answer, tell you how maybe how we can go ahead even in absence of these calculator. And more so, we do not have data on what we are growing. They are growing GBS, it's okay. They are screening their mothers frequently, weekly. We are not screening them. Probably because hardcore obstetrics is something which is uh, not it's actually losing its charm by the obstetrician. So they are not growing these organisms, trying to grow these organisms. I could not find even a single study. There's just one study from our own center. Other than that, I could not get much studies what is growing in these mothers to which we can target these antibiotics in antenatal period, because we are not screening. So what we are following is RCOG or ACOG, which may not be practically there with our FOXY. So FOXY needs its own data profile. So they are growing GBS. What we are growing, we don't know. And the calculator, the figure will change once you put in 0.5. Instead of 0.5, you have to put 1.6 or maybe even higher number, 2.6. So you will end up in giving to all. One was what to be given in infective endocarditis. So I posted the answer, firstly confirm the diagnosis, because in 2 decades I could see only one case of infective endocarditis, and cardiologists had very difficult time to diagnose it because the vegetations in newborn are not seen very nicely, but they are so small. So confirm the diagnosis, and obviously gram positive coverage has to be a strong one. Still, you can supplement anything else if you want to.
So, as you rightly pointed out, I have seen only one case of fungal endocarditis. Means, in fact, overall endocarditis, if you ask me, not with the bacteria. And there was a setting typically like extremely low birth weight baby, and then there was a center line, PIC line on the right side, and the tip was going into the SVC into the right atrium. So we had to continue amphotericin for a long time with the basic close monitoring. But I completely agree. Ultimately, for endocarditis, ultimately you need your culture report. If the culture report clearly shows, I think the job is done. You need to give prolonged therapy. If the culture report is not showing, but you are sure that it is endocarditis, then of course you need to cover both gram positive and gram negative and try to see whether it can be fungal or not. So I think there is no straightforward answer, but then you need to take help of your cultures, the setting, and to decide this.
And another was for the syphilis, somebody asked that we do not have crystalline penicillin in our area. And just to update, crystalline penicillin is not available in India. So it's not being manufactured now, and only some stock of benzathine penicillin is there. So you have to use that for syphilis. If anybody among the participants and the panelists knows that crystalline penicillin is there, they can update. But as far as I know, we do not have it.
So, ma'am, what you are saying is right, but I know offhand because I had a word with Dr. Arun. So, sir was telling once that he talked to that one fellow in Chandigarh itself, actually Mohali or Chandigarh, I'm not sure. So he said that he unofficially provided it basically. But so what you are saying is absolutely right. It is not available in the market as of now.
So the company that was producing it has stopped producing it. Maybe some old stock which is under black marketing may be going on. So what we do is syphilis we do get. It's not that it is not there. So we use benzathine penicillin and we keep on monitoring the titers. That's all. Somebody asked then a question about brand of lactoferrin. So I'm not still convinced that even the systematic review for the newborn for use of lactoferrin is not exhaustive. What we are extrapolating is from the adults. So, and it is not available in India. And what I know is only Tarno Modi had been using it in research. It's not made as a routine practice. If needed something more you know, then you can augment it.
Yes, ma'am. I think overall evidence is still low and we need more trials. And of course, if the trial shows, then we definitely have commercial preparations.
And then before you ended, once you ended, 2-3 more questions are there, and the question is from Dr. Amit Soel onwards. So I'll just read them for you. So one is, should lumbar puncture be done in suspected sepsis or blood culture positive sepsis?
So I think it's an interesting question. So remember that blood culture has to be done in all cases of early onset sepsis as well as late onset sepsis. There are only rare situations in early onset sepsis, like you have a newborn where there are some risk factors, the baby is asymptomatic. And you, in that situation, if the culture turns out to be sterile, you are not supposed to do. That is one exception in early onset sepsis. Second is the baby had distress. You had initially kept possibility of pneumonia versus TTM, and you have started antibiotics. And the baby is improving, which means it is TTM. Apart from that, in all cases of early onset sepsis, you are supposed to do lumbar puncture. And in all cases of LOS, there is no exception in it. Whenever you are suspecting late onset sepsis, LP has to be done. And the reason is that the positive predictive value of all clinical symptoms and signs, as well as the routine biochemical markers which you do, is pathetic in predicting meningitis. And even if you see that in the late onset sepsis, 1/3 of the cases of meningitis are those where the blood culture was sterile. So if you say that in late onset sepsis the culture was sterile, so I have not done lumbar puncture to rule out meningitis, it is not right. Rather, it may happen that the baby may present after 1 week or 2 weeks in your emergency or some other hospital, and the parents may sue you. So please take consent and do lumbar puncture in all these cases. Only 2 exceptions in early onset which I have told. Otherwise, for all cases, it has to be.
So just now, because NICE is under a draft for changes, and this draft came in December 2020. yet to be published. And again, what Neeraj has said, they have also summed up the same thing, all LONS and EONS. If you continued antibiotic for more than 48 hours, and the reason for continuing was that there is clinical sepsis going on, then you do in these EONS. But if the culture is sterile, baby has improved, there is no sepsis, then that is the only exception. The example he has already given, TTNB versus pneumonia, and it turned out to be TTNB. So now next question is there a gram positive sepsis versus gram negative duration of antibiotics?
So I think, as I earlier discussed, that whatever information we have, it's very the evidence is there is lacking. So no one knows. So conventionally, people have been using 14 days of antibiotics, whether it is gram positive or gram negative. If it is, if there is no meningitis, so there is no difference.
So maybe once Dr. Saurabh's trial is concluded, you might get some answer. Till then, even for cons, the treatment goes on for 14 days. Is that right?
Sorry, ma'am. In fact,
Is
the
that
trial
okay?
I told you, the study from Rohtak as well as this from Saurabh sir himself. So what they found that when they tried to stop antibiotics in the intervention group at 7 days, that there was relapse of gram positive.
So there is a big multicentric study going on by Dr. Saurabh only, and it's for 7 days versus 14 days in blood culture positive sepsis. So till we have, it's an ICMR funded project. So till we have the result of the study, we continue in all culture positive for 14 days. And the person who asked for infective endocarditis, he said he has seen 3 confirmed cases. So as answered earlier, look at the culture report and treat as per the sensitivity. Anything else you want to add to his infective endocarditis management?
No.
And then question is role of vancomycin in neonatal sepsis. I'm not able to understand this question. Role of vancomycin in neonatal sepsis.
So I think he must be talking as a sort of prophylaxis. So if you see, there is some evidence that if you use vancomycin logs and vancomycin infusions to decrease staph infections, though there is some evidence, but apprehensions are basically in terms of antibiotic resistance. So virtually no one is using vancomycin as a prophylactic therapy for preventing infections, especially in extremely low birth weight infants.
So just the hub care, which I think you showed the figures also, the pictures also. And asepsis, once you are opening the hub and injecting the drug, how the drug has been made, and you've taken proper cleaning of the hub before you attach syringe to it and give the drug. That is answer rather than inviting vancomycin lock and then resistance. Is it okay?
Yes, ma'am.
Then for Acinetobacter, what is the drug used?
I think you need to go with if you are able to grow Acinetobacter, then of course we'll get the sensitivity also. So I think you need to follow that. Unfortunately, if you see the data from Danish study, which I told you, so most of these Acinetobacter, almost more than two-thirds, they are multi-drug resistant. And in fact, we are also facing the same situation in our unit, and a lot of units are facing the same situation. So where we have to use cholesterol for this bug. But then if your bug is sensitive to piperacillin, tazobactam or meropenem, so as I said that please de-escalate to the narrowest spectrum antibiotic. So you need to go with your sensitivity and try to use narrowest spectrum antibiotic.
So what we use in our unit is ampicillin with sulbactam, because sulbactam is a very good drug against Acinetobacter. And once you stop an antibiotic and reintroduce after some time, then there becomes sensitivity to that also. So even Ciplox is showing sensitivity to Acinetobacter once we reintroduce the same after 2 years. So please, and another is quality improvement. So as Neeraj emphasized, even in the beginning, in the middle of his talk, see why it is growing. Your source of water, how you are preparing your injection. One of the things that we realized is that sisters, when they are giving drug to a baby, suppose it's a vancomyro or meropenem, then they have given to this baby and they will store the next dose in a syringe, or they will re-prick. That is to be totally discarded. So if you have 6 babies on meropenem in your unit, open one vial, give to all. If you have one baby in your unit getting meropenem, open for this baby and please discard it. If you do economic, cost effective or cost benefit analysis, discarding will definitely turn out to be cost benefit rather than you saving it and reusing it. It has been long proven and shown. So please look why Acinetobacter is growing, and look into your unit pattern of sensitivity of for this organism. And then, ma'am, for after how many days benzethrin penicillin has to be repeated? So we recently had a baby. There's no answer to it when it should be repeated. Like in cases of rheumatic heart disease, we had been giving 3 to 4 weekly. So what we did was before giving did titer. After giving we did titer. We were just monitoring the titer. Once the titer were less than 1:8, we stopped. So we didn't have to go for repeat dose in any of the baby, and we have around 5 to 6 babies per year. So look at the titers, just not the that whether VDRL positive or negative. And then should we use CRP to normalize when we stop antibiotics? So I think Neeraj already answered it. You can repeat the same. Maybe the candidate wants it again.
So there are few studies which have looked at this part. So some people have taken a cutoff of less than 10 milligram percent and as a single thing, or some people have taken two consecutive CRPs 12 to 24 hours apart. And if both the values are less than 10, they have stopped antibiotics. But so one may consider that, but then as I said that as of now, we don't have very robust evidence. So as of now, we are not following this practice in our unit, and probably we need more evidence in this direction. And what is your policy? Are you using CRPs to decide?
No, Neeraj, we don't use CRP to decide to start or to stop. We are not doing CRP. For early onset, we have totally abolished. Some of you may not like my answer, and most of you, not some, most of you may not like this answer. But the units, it's okay with SNCU where you do not have options, because some of you might be working in a setup which is an SNCU. So in SNCU, sending a blood culture is not always feasible, and they have to pay heavy amount for a blood culture. Then the guidelines are different. So see your setup. My setup doesn't need this. Your setup might need it to start and to stop both. So we are not using it.
So
And
I
for
would
late
just
onset sepsis also, we are not doing any CRP. It's only when we are stuck up with one or two signs and symptoms which are not clear cut, again to rule out, and not to rule in the sepsis.
So I think ma'am has rightly pointed out this important she has highlighted. We are also using CRP basically when we are suspecting healthcare associated infections or late onset sepsis. And again, it is primarily to rule out sepsis. So you have a plus minus kind of situation. Baby is having one episode of apnea, and you're not sure is it really infection or there was some mechanical reason at that time, or so, and everything else is fine, you're closely monitoring. So those kind of situations you're not very sure, there you do CRP. If the CRP is negative, at least you know that the chances of infection is less. And to be more precise, if you do two consecutive screens or CRPs at this time in an interval of 12 to 24 hours, and if both are negative, then the negative predictive value is almost 99%, which means that there are 99% chances that if your two CRPs are less than 10 milligram per liter, then the 99% chances are that the baby is not infection. But suppose if it is positive, then the positive predictive value is very less, 30-40%. So,
Needed, is confusing about CRP is anything more than 10. So anything more than 10 up to 110 is very broad. So
agreed.
if you are dealing with a CRP which is 50, 100, definitely you should treat. But for a CRP of 15, baby having recurrent apnea, so now this recurrent definition you should know. It is not always mechanical. It may be because somebody did not give the capnia, or the capnia dose is less, or your interface is coming out. There was a local induration at the site. So you rule out all these things. Your nutrition may be poor. Baby will not come out of the apneas. So sepsis is highly misinterpreted in neonatology, And that is why probably people outside the neonatology makes a mockery of neonates that everything here is a sepsis. So please do not allow anybody to mock at you. Everything is not sepsis. So look at the baby. There's no shortcut to close clinical monitoring. So this close clinical monitoring, look at the baby, look at the nutrition, look at interface, look at the cause behind apnea. Like what we teach in MBBS, you write down a problem and then think all the possible differentials to it, and then only go ahead. Suppose in a night a baby had 6 to 8 episodes of apnea. He is not at all maintaining. Then this baby is different from a baby who is having 1 to 2 apnea every night. So both the babies are different. Both babies have recurrent apnea. So you have to define what recurrent apnea is. And definitely the first baby where it was occurring almost every half an hour to 1 hour, despite corrective measures, despite that your apnea dose was correct, here you do the screen like the way Neeraj has told, and then you may upgrade your antibiotics.
So, Dr. Amit, as you have pointed out, that should we use CRP to normalize? Should we wait? I think we should, right? Should we wait CRP to normalize when we stop antibiotics? So, answer will be no. So, no one looks at CRPs that one is normalized, and then, as I said, that antibiotic duration is purely arbitrary as of now. Okay. So, one last question, I think, from same Dr. Amit. What are the lab test bundle in today's date that make a best septic screen with highest negative predictive value or positive predictive value? So most of these tests which are available, they have a good negative predictive values, and the best is if you use a combination of CRP plus PCT. If you see the or if you don't have the facilities for PCT, then you can use two screens, two combination of CRP PCT. If you have that facility, you can afford, because PCT is a costly test. So others like
I think now we can sum up. Akash, is it okay to sum up now?
Yes, ma'am.
So to sum up, just a practical tip, if I am there for early onset neonatal sepsis, so there are three approaches which is being used and developed. One is risk assessment, as the NICE keeps on saying, NICE guidelines. Then is your sepsis calculator, and then is your clinical monitoring. So we will go by our scenario. Our scenario where we have red flag signs available with us. And in case the red flag sign is not there, just one clinical indicator, one non-red flag, which is the most common confusing condition. Neeraj gave the example also. You have a less than equal to 32-week baby who is iatrogenic preterm and has RDS because of prematurity or apnea of prematurity. Now, in these babies, nobody has a clear-cut answer to start or not. There is a very small trial by name of Reason trial. It is very small. And here one baby died in the group which did not get the antibiotic. So you cannot conclude that I will not give. So answer is you start, send your blood culture. If the culture is sterile, now the two scenarios will be there. Culture is sterile, baby is still on respiratory support. But on respiratory support, if the baby has improved, you can withhold antibiotics. If it is sepsis, it will resurface. No sepsis sits silent for long. So how you will go ahead? So do the clinical monitoring. If you had stopped, withheld, or not started, do a very close clinical monitoring. Maybe if you had not even started, half an hourly for first 2 hours or 4 hours, and then every 4 hourly. And clinical monitoring in baby every hourly is good enough to pick up all these symptoms. Then for your late onset sepsis, there are lots of signs and symptoms. Lab blood culture is the only gold standard. And if you're looking for acute phase reactant, no single acute phase reactant will give you the answer. We already gave you how we are going with acute phase reactants. We have totally stopped any acute phase reactant for early onset. For late onset, we send CBC also, then CRP if we want to rule out, not to rule in. If there's sclerema, there's bleeding, there's whiteout of lung because of flooded secondary infection, then we don't do any investigation. We have to treat the baby because it's a clear-cut case of infection. Why do you want to prick to do CRP? So rationalize your investigations also. Then anything else? So clinical monitoring, as I told you, the sepsis risk calculators, they are not being validated for your system. So please avoid using them in your system till we validate them. Now there is one very good data by again by Dr. Saurabh. It's a 10-year study they have compiled from the McMasters, where they have looked, because it's all backtech based. What Neeraj is doing or I am doing, we have backtech in our own unit, and we know once the alert is coming. So if you have a backtech in your system, early onset sepsis gives alert very rapidly. And if the alert has come in less than 24 hours, it's gram negative. If the alert and you is coming after 24 hours, it may be gram positive. So you can withhold your gram negative treatment and you can go ahead with gram positive. It's an observational study, but we need to generate our data. Problem with us is we are not venturing into any such data. Even our India newborn collaboration data is talking only about antibiotic duration and days. What we need is a data on these ambiguous situations which we discussed of less than 32 weeks and other is more than 35 weeks with chorioamnionitis. So here both of us may differ, including the person who is presenting and myself, to treat or not to treat. We go by clinical monitoring without treating this chorioamnionitis baby. As I told you, sepsis doesn't sit silent. So if there is no symptom, I will wait and watch. But my monitoring will be half hourly for first 4 hours and then hourly, not 4 hourly. So the data which Dr. Pauline Fox has generated is 4 hourly. We do it hourly, not 4 hourly. And if the baby is okay for 48 hours, then we feel safe. We just monitor it for another 48 hours and discharge the baby. But for such things, we need a multi-centric data. Most of the centers do not have data, and we are going by the Western world data and waiting for that. Whereas we have more disease load, so we can generate our own data. This is what I have to say. And Akash, I think Akash and Neeraj, you can add on it if more to be added to it.
Thank you so much, ma'am. I think Dr. Neeraj and you have already covered majority of the sepsis, and there is hardly anything left me to cover. But again, I will just sum up in one line that use antibiotics rationally. Don't use antibiotics as a tonic, and it has not to be given unless you are strongly suspecting sepsis. And once your cultures are negative, and have confidence in your cultures and stop the antibiotics.
So
Anything?
what we do is once we have stopped, we do not discharge. We keep this baby for another 48 hours. So stopping is or withholding is more difficult than continuing. So let's choose the difficult path and do a rigorous clinical monitoring and then give a happy baby back rather than a baby who later on will become obese, will be asthmatic with inadvertent use of antibiotics or may not survive even the neonatal period.
Very rightly said, ma'am. So I think you have anything to say, sir, before we conclude, Dr.
No,
Neeraj?
no. I think
Uh,
if anyone has any queries, so we can take. Otherwise, we close.
I think that was very elaborative and well covered. And congratulations to the speaker and the moderator, ma'am. And with that, we conclude today's session. And thank you so much, ma'am, for being with us. And thank you, Dr. Neeraj, sir, for covering this topic elaborately. It is one of the most common causes by which we lose our babies and they'll end up in morbidity. Thank you so much.
Thank you, Akash, and thank you, Neeraj, and thank you the whole team of Lucknow and the series. So maybe it's a never-ending discussion on sepsis.
Thank you, ma'am, and thank you, Dr. Akash, and the entire Lucknow Immunology Forum, as well as the participants who are still here till 10 o'clock to listen and participate. And so, thank you, everyone.
That too, despite a final ODI going between India and England. So, double congratulations. Thank you so much, ma'am, and thank you.
And going by the fact I sleep at 9 and get up at 3 a.m.
Thank you so much, ma'am.
Okay, thank you.
So, pleasure to have both of you.
Thank you.